Bismillah ar-Rahman ar-Rahim. My name is Mohamed Shatila. I'm one of the clinical fellows of thoracic surgery in QE Hospital, Birmingham, UK, and one of the lecturers of cardiothoracic surgery at Alexandria University Hospital in Egypt. And I'll just give a talk today about the 8th edition of TNM staging of lung cancer. I'll just have a quick talk about the history. And the first substantial revision of the lung cancer TNM staging was actually proposed by Dr. Mountain et al. In 1973. He published a paper called The Clinical Staging System for Lung Cancer. And this work was based on the outcome of 2,155 cases, out of which 1,712 were non-small cell lung cancer, and obviously the rest were small cell. So this was the first one. It was done back in 1973. And you can see that the number of cases was only 2,155, and the one number of non-small cells, 1,700. And then they started going to different editions till they reached the 7th editions of the TNM staging of lung cancer, which started in 2009. It was published in 2009, and this included data of 81,496 patients, and you can tell the difference between about 2,000 patients in the first edition and going up to about 81,500. There has been limitations on the 7th edition, and for that reason they upgraded it to the 8th edition. But to be honest, some of the limitations in the 7th edition are still present in the 8th edition, and we'll have a talk about that. The first thing was that it was an inadequate worldwide distribution, so it wasn't adequately distributed. And you would realize that when you talk about the 8th edition of TNM staging of lung cancer, there are nearly no patients from Africa, for instance. So it's not equally distributed in the world. Now, this paper was published in 2009, but they started collecting the data in the 90s. The PET scan was not very much available at that time. So the staging was not as accurate as it is now. So then they started doing the 8th edition, and they started collecting the data from the 8th edition in 1999, and it continued to 2010. That's about 10 to 11 years. And it included 16 different countries, and there were 35 different sources. It was a total of about 95,000, out of which only 77,000 patients were finally included inside the study, and the rest of the patients either did not have histologies, incomplete stage information, so they weren't very accurately staged. There was something wrong with their staging system, so they just took it out of the number of patients that were included in the beginning of the study. So at the end, they were 77,000, out of which about 71,000 of them were non-small cell lung cancers, and the rest were small cell lung cancer. And if you look at the geographical distribution, this is quite interesting actually, because the majority of the patients are actually from Europe, and then Asia is mainly from places like Japan and Korea and China. So this is where they took the lung cancer patient. Less representation from North America, but there are nothing here related to Africa. So I'm from Egypt, and as Africans, we were not even included in the TNM staging system, obviously, because we were not able to provide these sources of information to help in this staging system. So this is just a brief introduction about the history, just a very brief introduction about the history of the TNM staging system that we should just have an idea about. Now we go to a bit medical, and the first question is, why do we stage? And I'm sure that all of you know the answer to this question. And as a very simple answer is, it helps you treat. It's just for knowing what treatment to give to a patient. The TNM staging of lung cancers tells us more than just treatment, of course, but it's the main thing. It tells us the extent of the disease, so how far the disease has actually progressed and how far the disease is. It gives a very good idea about the prognosis, and then obviously it gives us a lot of information about the treatment. So if you remember these 3 points, extent, prognosis, and treatment, you will get an idea of why we stage any kinds of cancer. The bodies that formally decide on the definition of the TNM staging system are the American Joint Commission on Cancer, that's in the States, and the Union for International Cancer Control, and that's something international. So these are the two committees or the two commissions that actually decide on what to call the T stage and what is T1, what is T2, what is T3, and so on. So these are the two commissions that actually tells us what each category of the TNM staging system means. So a staging system would have 3 components. Obviously, the first one would be T, which represents the characteristics of the primary tumor. Second one is N, which is the lymph nodes, and third one is M, which is the metastasis. So before I start talking about the classification of the tumors and so on, I just want you to go back a little bit into some of the important definitions and terms that we might be using in the classification. And according to the BTS guidelines for the investigations of management of pulmonary nodules, obviously because we're in the UK here and this is the guidelines we use, I just want to make sure that everybody's aware of certain definitions and terms that we use. For example, what is a pulmonary nodule and what are the classifications of the pulmonary nodule here. So you've got something called a pulmonary nodule, and then they're classified into solid and subsolid are further classified into part solid and pure ground glass. So we should actually know what this means. So in terms of size, when you use the term nodule, that means it's less than or equal to 3 centimeters. It's focal, round, opacity. It should be surrounded by aerated lungs, including contact with pleura. And this is the classical definition of a nodule. So just to clarify it, less than or equal to 3 centimeters. Now, a pulmonary nodule could be completely solid or could be subsolid nodule. Subsolid nodule, from its name, that means part of it is solid, part of it is not solid. So it could be a part solid nodule. That means it consists of 2 components, a solid and a ground glass component. Or a pure ground glass nodule, which means that it's only formed of a ground glass component. So again, a nodule has to be less than or equal to 3 centimeters. It's classified into solid or subsolid. Subsolid nodule would be a part solid nodule, which means it consists of a solid component and a ground glass component, or a pure ground glass nodule. Now you might be a little bit surprised about what's this picture. Actually, this is a picture of a hand behind a mirror, and this is ground glass. This is not, this is just to make you understand how a ground glass would look like. You would actually see this kind of appearance, and that is what ground glass is. So these are 3 images here, axial cuts of CT scans showing the 3 different kinds of nodules. And obviously the one on the left side here, this is a very solid nodule, speculated, very suspicious for lung cancer. And then if you look at the one here on the top right, did you realize that this is the one that is what we call as a part solid nodule, which consists of a solid component and a ground glass component. And then if you look at the one at the bottom here, this is pure ground glass nodule. So these are the 3 different kinds of nodules that we talk about. Now, as we've said, a nodule is less than or equal to 3 centimeters. A miliary nodule is less than 2 millimeters, and a pulmonary micronodule is less than or equal to 3 millimeters. So some people would say that a pulmonary nodule is actually 4 to 30. Now, millimeters, of course. Now, what is more than 3 centimeters? Anything that's more than 3 centimeters is called a pulmonary mass. So it's very important. You have to know the difference between what is less than or equal to 3 centimeters and what is more than that in terms of definition of terms. So one is called a nodule, the other one is called a mass. Now, this is also from the BTS guidelines, and it says the aspects of the new classification of adenocarcinoma in relation to the nodule type. And in its definition on this table, it says that you've got 2 kinds of lesions that we consider as pre-malignant, and obviously the other 2 are invasive. So you've got the atypical adenomatous hyperplasia, you've got the adenocarcinoma in situ, which are pre-malignant conditions, and then you've got the minimally invasive adenocarcinoma and the invasive adenocarcinoma. So what are actually the difference between these terms? What do they actually mean? And then you can see on the right-hand corner, it says CT correlates for the sizes. So for instance, an atypical adenomatous hyperplasia is a ground glass nodule less than 5 millimeters. An adenocarcinoma in situ is a ground glass nodule that is more than 5 and up to 30 millimeters. And then you've got the minimally invasive, which is a part solid nodule. It says here containing a solid area less than 5 millimeters. And then the invasive adenocarcinoma would be a larger part solid or solid nodule. And I will go through them again. So again, in terms of definition, let's start taking them one by one. So in a typical adenomatous hyperplasia, we said, based on the diagram on the table we showed in the previous slides, is a pre-malignant condition. And then you have to know what the size is. So it's less than 5 millimeters in size, and it has a character of a pure ground glass nodule. So on a CT scan, a ground glass nodule that's less than 5 millimeters is an example of an typical adenomatous hyperplasia. And this is actually quite a normal finding. We find those adjacent to recently resected adenocarcinoma. And if you see a patient who's had, for instance, a right upper lobe adenocarcinoma, and you did a right upper lobectomy, and then you send it for histology, and it's not uncommon, maybe up to 23%, that the patient, the histologist, or the pathologist would comment on the adenocarcinoma that you resected, but he could also say that at the edges of the adenocarcinoma have areas of atypical adenomatous hyperplasia. Now, sometimes a small but unknown proportion exactly of this atypical adenomatous hyperplasia progresses to what we call as an adenocarcinoma in situ. And the difference is both of them have a ground glass appearance on a CT scan, but the sizes are different because an adenocarcinoma in situ is actually more than 5, less than or equal to 30 millimeters. So the size here is different, but they both are ground glass nodules on CT scans. So again, an adenocarcinoma in situ, localized adenocarcinoma up to 3 centimeters. It will appear as a ground glass nodule, and it exhibits what we call as a lipidic growth pattern. So what is a lipidic growth pattern? A lipidic growth pattern means that the tumor cells are actually proliferating along the surface of an intact alveolar wall, but they don't go downwards. The tumor cells are actually growing across the wall of the alveoli, but they don't penetrate downward. They don't invade the stroma and the vascular structures inside. And that is why it has this ground glass appearance. But once it starts penetrating downwards, on the CT scan, it would have a characteristic solid appearance. So then this adenocarcinoma in situ starts to change into an invasive adenocarcinoma. And the first stage of an adenocarcinoma in situ becoming an invasive adenocarcinoma is termed as minimally invasive adenocarcinoma. And what it actually means is that when you look at this lesion, you'd realize that, yes, it's less than 30 millimeter ground glass nodule, but inside this ground glass nodule, you've got a solid component that's less than 5 millimeters. And the reason why you've got a solid component that's less than 5 millimeters is because part of this adenocarcinoma in situ, part of the cells of the adenocarcinoma in situ, those malignant cells, started to proliferate downwards. And so they started to appear solid on a CT scan. And so this is just a diagram that I drew just to make you understand the difference between two. For an adenocarcinoma in situ, it's less than or equal to 3 centimeters. You've got a ground glass nodule. You've got a lipidic growth patterns. So looking at this, you'd realize here that the cells are actually just proliferating across the intact alveolar wall. But then part of these cells that are growing across the alveolar wall start to penetrate downwards. They start to go downwards. They start to go into the stroma and the blood vessels. And then this part becomes a bit more solid. And so you start getting a minimally invasive adenocarcinoma, which is a ground glass nodule less than or equal to 3 centimeters. But inside this ground glass nodule, you've got a solid component because it proliferated downwards. But this solid component has to be less than or equal to 5 millimeters. And remember, this is quite important to understand because once you see a solid component in a ground glass nodule in a CT scan, then it has become invasive. So let's go to the next part of the presentation. We've already talked about some of the important terms and the definitions of these terms. Now let's just go back to tumor staging. And obviously, tumor staging is presented with the letter T. And a staging of a tumor depends on not just size. So size is one way in which you can stage T, but there are other things that are also important, which is the local invasion, endobronchial extension, and separate tumor nodules. And we will go through those step by step. So a paper has been published called the 8th edition of TNM staging of lung cancer in the Oncologist. It has a lot of charts and diagrams. That talks about the staging, the TNM staging of lung cancer, the 8th edition. And it has very good representative diagrams. And so the first thing we're going to talk about is the primary tumor T. And you realize that he's put it in one diagram here, and it says on the top left-hand corner, tumor size. Then he's talked about the size. He's talked about the endobronchial extension. He's talked about the local invasion in B. And then he had to talk about the separate tumor nodules. So he's put them all in one diagram, and we will talk about it step by step. For size, the 8th edition has classified it into T1A, T1B, T1C, T2A, T2B, T3, T4. Okay? So we've got from T1 to T4. T1 is subclassified into A, B, C. T2 subclassified into A and B. And then we started using sizes. So for instance, a T1A tumor, and if you look at the number 1 here, it's actually less than or equal to 1. A T1B tumor is less than or equal to 2. A T1C tumor is less than or equal to 3. Okay? And then when you go to TA tumor, it's less than or equal to 4. T2B tumor, less than or equal to 5. And then from 5 to 7 is T3, and more than 7 is T4. Now, let's not look at the part on the top here. I will explain this at the end. Let's look at the part here. So a T1A tumor is less than or equal to 1 centimeter, which we've just said. And again, a T1B tumor is obviously more than 1, but less than or equal to 2. And a T1C tumor is going to be more than 2, but less than or equal to 3. And so on. And we go downwards. We go into higher sizes as we reach T4. Now, a very important thing is what happens if a tumor is, for instance, 2 centimeters? Would that be a T1B or a T1C? Okay, let's look at it again. So a 2 centimeter tumor, would it fall into T1B or would it fall into T1C? So it says here it's more than 1, but less than or equal to 2 centimeters is a T1B. So a 2 centimeter would be a T1B. For instance, for example, a 3 centimeter would be a T1C, and so on. Because sometimes when they do the report, they say tumor size 2 centimeters, and people sometimes get mixed up. Is that a T1B or is it a T1C? No, 2 centimeter, for example, would always be a T1. Okay, so this is the first thing that we've classified tumor based on size. Now, let me just add this table here, and I think it's quite important that we really understand this. We did on the previous slides have a bit of a discussion about what an adenocarcinoma in situ means and what is a minimally invasive adenocarcinoma. But then we want to find out exactly where they are placed in the T classification based on size. So we know that a T1A tumor is the tumor that's less than or equal to 1 centimeter solid tumor, and a T1B is from more than 1 but less than or equal to 2. And you've got a T1C, which is more than 2 but less than or equal to 3 centimeter solid tumor. Now, if I've got a adenocarcinoma in situ, which is given, it's written as TIS, which means that, as we have said, it is a ground glass nodule that is less than or equal to 3 centimeters, but it's pure ground glass on a CT scan. So if you've got this nodule, this pure ground glass nodule that's less than or equal to 3 centimeters, we call this as a TIS, or adenocarcinoma in situ. Now, once you start getting an invasive component, then it automatically jumps into T1. So a T1MI would be less than or equal to 0.5 centimeters solid part within part solid tumor, total size less than or equal to 3 centimeters, which if you look in the first figure here, if I consider the blue part as the pure ground glass nodule that I have, and then on the yellow part, you've got a solid component. Now, the solid component inside the pure ground glass nodule is less than or equal to 0.5 centimeters, and the complete ground glass nodule is less than or equal to 3 centimeters. So you call this as a T1MI. Now, if the solid component starts to increase in size, that means it becomes more than 5, that is 0.6 to 1 centimeter. So if you've got an increase in the solid component, but the ground glass nodule is still less than or equal to 3 centimeters, you call it a T1A. Now, if the pure ground glass nodule increases more than 3 centimeters, you also call it a T1A. And obviously, a tumor that's less than or equal to 1 centimeter solid. What about a T1B? Well, if the solid component inside this ground glass nodule becomes from 1.1 to 2 centimeters, but you've still got the ground glass nodule less than or equal to 3 centimeters, you call it a T1B. Or if a solid tumor is more than 1 but less than or equal to 2. What about a T1C? Well, either one of two. Either you got a solid tumor that's more than 2 and less than or equal to 3, which we previously discussed, or the solid component inside that ground glass nodule becomes from 2.1 to 3 centimeters with, as we said, the ground glass nodule less than or equal to 3 centimeters. The second thing we're going to talk about is the classification of the T tumor based on endobronchial extension. So, this has actually changed between the 7th and the 8th, and we will talk a bit more in details about what actually happened between the 7th and 8th. So obviously, if you've got a tumor that's growing inside the bronchus, would you call it a T1 or a T2 or a T4 or what would you call it? So the classification, the new TNM classification, 8th edition, said that if it is in the distal or if it is distal to the lower bronchus, remember this is the trachea, this is the left main bronchus, and this is the right main bronchus. And then you've got here, this is for instance, the upper lobe bronchus and lower lobe bronchus. So any tumor that's in the lower bronchus or distal to it, for example, if it's in the left lower lobe bronchus, if it's in the left upper lobe bronchus, or distal to that these tumors are classified as T1. Now, if a tumor is in the main bronchi, for example, the left or the right main bronchus, all the way to the carina, so the tumor extends all the way up to the carina, or a tumor that has caused complete post-obstructive pneumonitis or atelectasis, complete, remember the term complete, so it's completely obstructed the lung on one side. These tumors are classified as T2. Now, endobronchial extension, there is nothing in T3. But if a tumor reaches the carina or spreads into the trachea or is found into the trachea, it's called T4. Okay? So if it is at the lower bronchus or distal to the lower bronchus, it's a T1 tumor. If it is in the main bronchus up to the level of the carina, or it has caused some sort of post-obstructive pneumonitis or atelectasis, it's called a T2 tumor. If it's involving the carina, if it's involving the trachea, it's called a T4 tumor, and T3 tumor has not been added into the subclassifications of tumor based on endobronchial extensions. What about local invasion? Again, we've talked about the size, we've talked about the endobronchial extension to classify T tumors. Now let's talk about the local invasion of the tumors. So the local invasions of the tumors are quite straightforward. So T1 tumors, classification based on invasion. T1 tumors will have no invasion. A T2 tumor would invade the visceral pleura. Remember, there's a visceral pleura that coats the lung, and then you've got the parietal pleura covering the chest wall. If it just reaches the level of the visceral pleura, automatically it's called a T2 tumor. Okay? And then now you've got T3 tumor. A T3 tumor would extend more than the visceral pleura. So it goes to the chest wall, it goes to the parietal pleura or the parietal pericardium, and it goes to the phrenic nerve. So a T3 tumor will extend all the way to the chest wall, or it will go towards the parietal pericardium or the parietal pleura, or it involves the phrenic nerve. Now, what is a T4 tumor in terms of local invasion? The T4 tumor would involve the diaphragm, the mediastinum, the heart, the great vessels, the recurrent laryngeal nerve, esophagus, and vertebral body. So looking at them, remember that if it involves the phrenic nerve, it's called a T3 tumor, but if it involves the recurrent laryngeal nerve, it's called a T4 tumor. Okay? If it involves the parietal pericardium, it's a T3 tumor, but if it involves the heart, it's a T4 tumor. If it involves the chest wall, it's a T3 tumor, but if it involves the diaphragm, it's a T4 tumor. So this is very important to understand the different staging of the tumor based on local invasion. So then now we're talking about tumor nodules. So for instance, if you've got a tumor, and let's say, for example, you've got the primary cancer is in the right upper lobe, and then you've got a satellite, which is a satellite that is present on the same side and on the same lobe. For example, you've got a primary tumor on the right upper lobe, and you've got a satellite also on the right upper lobe. This automatically is called T3. Now, if you've got a tumor in the right upper lobe, but you've got a satellite which is present on the right lower lobe, we call that a T4. So if it's on the same lobe, it's a T3. If it's on an ipsilateral lobe, it's called a T4. Now, if it's on the opposite side, that is, for instance, you've got a tumor on the right, but now you've got a satellite on the left side, not related to T, but this is related to M, and we will talk about that. He's also mentioned here, and you can see on the top left-hand corner, he says that all the superior sulcus tumor are staged as T3. So another very interesting slide is the slide that compares between the 7th and the 8th edition regarding the T descriptors, which is the T, based on size. So let's just go through it and try to understand what actually happened on the 8th edition compared to what was present previously on the 7th. So the TX, which means the tumor cannot be assessed by imaging, and the T0, which means no evidence of primary, and T on ice, which is the carcinoma in situ that we previously talked about, they more or less remain the same. No changes between the 7th and 8th, so exactly identical. But then we start going into the T1As and the T1Bs and so on, and there's a difference between both editions. On the 7th edition, there was a T1A and a T1B. There was no such thing as a T1C on the 7th edition. This is added onto the 8th. On the 7th, a T1A would extend from the tumor side would extend all the way up to less than or equal to 2 centimeters. So there weren't this 1 centimeter interval. But then when we made the 8th edition, they further subdivided it into a tumor that's less than or equal to 1 is called the T1A, and a tumor that's from 1 but less than or equal to 2 centimeters is called the T1B. And on the 7th edition, this was all called the T1A. The T1B tumor in the 7th edition was a tumor that is more than 2 but less than or equal to 3 centimeters. This is called the T1C tumor on the 8th edition. Same thing happened in T2. So a T2A tumor would be a tumor that's more than 3 centimeters but less than or equal to 5. So it was 2 centimeter interval. But then on the 8th edition, they subclassified it into T2A, which is more than 3 less than or equal to 4, and a T2B, which is more than 4 less than or equal to 5. A T2B tumor was more than 5 and less than or equal to 7 centimeters. And if you remember from the presentation, this is actually now called a T3 tumor. And then you've got a tumor that's more than 7 centimeters is called a T3 tumor on the 7th edition, but on the 8th edition now it's called the T4 tumor. Okay, so here we've got another diagram that's just comparing between the tumor descriptors, the T, between the 7th and the 8th edition, and what are actually the differences. So it's quite, I think we should have an idea about the differences. So for instance, on the 8th edition, if you say that a tumor is involving the main bronchi, left-right main bronchi, as long as it's more than 2 centimeters from the level of the carina, it's given T2, but this has actually changed a little bit on the 8th edition, because if it's less than 2 centimeters from the carina based on the 7th, it's called the T3. But the 8th edition have changed it. So they've said as long as you've got a tumor inside the main bronchi, the left or the right main bronchi, up to the level of the carina, it's called 2. Invasion of visceral pleura was the same in the 7th and 8th edition. Now, obstructive atelectasis, if it's partial obstruction, it's both the same in the 7th and 8th edition, but whole lung obstruction was previously called T3 in the 7th, now it's actually T2. Invasion of the chest wall, parietal pericardium, and the phrenic nerve are both T3 in both editions. Local invasion of the diaphragm. In the 8th edition, it's T4, but on the 7th edition, it was a T3. Invasion to mediastinum, trachea, heart, great vessels, esophagus, recurrent laryngeal nerves, vertebra, and carina are both T4. Satellite nodule on the same lobe are both T3. And satellite nodule in different lobes are also both T4. So now we've got the N standing for the lymph nodes. We finished the T, now we go into the N. And so there's no difference between the 7th and the 8th edition. So NX, regional lymph nodes cannot be evaluated. In N0, there are no involvement of lymph nodes. And then you've got the N1, which are the hilar ipsilateral group of lymph node involved. So involvement of the ipsilateral peribronchial and/or hilar, ipsilateral hilar lymph nodes, obviously including direct extension to intrapulmonary nodes. And then you've got the N2, which means that you can get involvement of the ipsilateral mediastinal and/or the subcarinal lymph nodes, which are station 7. And then N3, then you've got involvement of any of the following lymph node groups. You've got a contralateral group, contralateral mediastinal, contralateral hilar, ipsilateral or contralateral scalene lymph nodes, or the supraclavicular lymph nodes. So it's exactly the same as the 7th edition. No changes happened between both. Just remember that they're exactly the same classification. Again, from the same paper that we previously talked about, the 8th edition of TNM staging of lung cancer, and it's from the oncologist, published in the oncologist. And if we look at this paper, they've also done a very nice diagram here, which is illustrating the lymph node involvements and whether they would be an N0, N1, N2, N3. Now, just to note that there are no differences between the 7th and 8th edition. They're more or less, they actually stayed exactly the same. So I'm pretty aware that most of you are aware of the lymph node stations, and just to go through them, because it's exactly like the 7th edition. An N0 means there are no lymph node involvements, and then when you come to an N1, then means you've got involvement of the ipsilateral peribronchial or ipsilateral hilar lymph node, which is any lymph node from station 10 downward. Or sorry, it would be from station 10 upwards, like 10, 11, 12, and so on. N2 involvement of the ipsilateral would be involvement of the ipsilateral mediastinal or the subcarinal group of lymph nodes. N3 involvement would be involvement of any of the following lymph node groups. This could be the contralateral mediastinal, the contralateral hilar, the ipsilateral contralateral scalene, or the supraclavicular lymph nodes. So it's also quite interesting here, because here it says, on the diagram, it says here an N0, which means no lymph node involvement. And then you've got the N1, which is the hilar group of lymph nodes. And then N2 would be the ipsilateral, same side. N1 would be the hilar group of lymph nodes, and N2 would be the ipsilateral mediastinal group of lymph nodes, including the subcarinal group of lymph nodes. And then N3 would be contralateral hilar, contralateral mediastinal, ipsilateral or contralateral scalene, or supraclavicular lymph nodes. Anyway, no difference between it and the 7th edition. So what about the M, which represents distal metastasis? So obviously M0 means no distal metastasis, and then there's a bit of a difference between it in the 7th and 8th edition. So M1A represents malignant pleural or pericardial effusion, or pleural or pericardial nodules, or separate tumor nodule or nodules in a contralateral lobe. And M1B is a single extrathoracic metastasis. And now we've got also M1C. So what is the difference between an M1B and an M1C? So M1B means you've got one organ with a single metastasis. But in M1C, you've got multiple extrathoracic metastasis. Now, this could either be multiple metastases in one organ or multiple metastases in more than one organ. So I hope you understand the difference. So if you've got, for instance, a single metastasis in the adrenal gland, it will be an M1B. But if you got multiple metastatic lesions in the adrenal gland, it will be an M1C. If you've got single metastasis in the adrenal gland, is an M1B. But if you've got metastasis in both the lung, in both the adrenals and the brain, for instance, it becomes an M1C. Again, the same paper again, and the diagram showing the different metastases. M0, obviously you can see that on the diagram here on the top. M0, no distal metastasis. And then you've got the M1 group, which are classified into M1A, B, and C. And obviously, it's exactly like we said on the previous slide. M1A, malignant pleural pericardial effusion or pleural pericardial nodules, or separate tumor nodule or nodules in a contralateral lobe. And then you got M1B, which is the single extrathoracic metastasis, and M1C, which is the multiple extrathoracic metastasis. So now we come to a bit of an important yet boring part, which is the staging of lung cancer. It's quite tricky to remember them. So it's always nice for you to have a diagram or a scheme that can helps you actually in knowing the staging system of the lung cancer. So you've got a stage 0, you've got a stage 1, which is classified into 1A and 1B, and 1A, you've got 1A, 1, A2 with A3. You got stage 2, which is a 2A and a 2B. You've got stage 3, which is 3A, B, and C. And you've got a stage 4, which is 4A and 4B. Another way in which I did, because I said that this is my drawing here. So this has got a stage 1, you got a stage 2, you got a stage 3, and you got a stage 4. So obviously any stage 1 tumors will always have an N0 and an M0. So this is the first rule. When you look at the stage 1 tumor, it has to be N0, M0. So no lymph nodes, no spread. It's further classified into A and B, and A is classified into A1, A2, A3, and a B is classified into just B. So an A1 tumor would have a T1A tumor, an A2 tumor would have a T1B, and an A3 would obviously have a T1C, and a B tumor would have a T2A. So for instance, if you want to say stage A 2 would be a T1b tumor, N0, M0. What about a stage B? It's a T2A tumor, N0, M0. What about stage A3 tumor? It's a T1C, N0, M0. So basic rule is stage 1 will have N0, M0. Now, when you start going down to another stage, it becomes a little bit complicated. So we've got a stage 2 here. It's classified into stage 2A and a stage 2B. So a stage 2A would also have an N0, M0, and it will be continuation of the T staging from stage 1B. So it's going to be now stage 2B. It was previously 2A. Now it's 2B. But again, it has to be an N0, M0. Now, when you jump into stage B, there are two types of stage B. Either you say a T3, which is progression in size of the tumor from the previous stage, but you have to have an N0, M0, or you say it's a stage 1A tumor all the way down to 2B, okay, but you have to have an N1. So stage B tumor, stage 2B, apologies, has an N1 disease. So now we are going to nodal diseases. It doesn't have to, because it could be just based on size with an N0. But once you start to go into stage 2B, you have to make sure that you have to know that we're going into an N1 disease. Now we go to stage 3 tumor, which is even a little bit more complex, but just try to think about it. So it's classified into A, B, and C. And a stage 3A tumor would be a tumor size from 1A all the way to 2B, but now we've got an N2 disease. Okay? Or a T4 N0 M0. So slash N1, sorry. So it's a T4 N0 N1. So a stage 3 tumor, A, would be any tumor size from T1A all the way down to T2B, but it has to have an N2 disease, or a T4 tumor with an N0 N1. A stage 3B would be any size from T1A to T2B, but it should have an N3 disease, and a T4 N2. And a stage 3 would be either a T3 and a T4, but it has an N3 disease. And then you jump into stage 4, which is classified into A and B. So this is any T, any N, but it has to have an M1A, M1B. And a stage 4B tumor would be any T, any N, but now you've got an M1C. And we've talked about the M1Cs. So should you memorize them? No, just remember this picture. Take a screenshot from this picture. Keep it next to you. It makes things so much easier for you. And then you'll be able to actually recall any kind of tumor. So for instance, if you've got a T1 tumor with an N0 lymph node, it'll be T1A. For instance, any T1 tumor with an N0 lymph node is a T1A. Let's, for example, take this example. So if you've got a T2B tumor with an N2 lymph node, it'll be a 3A. If you've got a T4 tumor with an N3 lymph node, it will be a 3C. And any M1A, any M1A would be 4A, any M1B would be 4A as well. Any M1C would be 4B. So it's just a diagram that just you can easily get all the kinds of information that you need just from this diagram, and makes it a bit easier. And I think if you just keep a screenshot of this diagram, you'll be able to recall anything. So when a patient comes to clinic, just look at his lymph node staging. Let's look at his T and the N and the M, and then you can easily get the stage. This is an interesting paper that has also been published. It's called the 8th edition TNM's classification for lung cancer and what does it mean on Main Street. And he just put some key features, and these key features are the distinguishing. Again, all papers like to add the table that actually talks about the difference between the 7th and 8th edition. Here he summarized them all in one table. He said the tumor size is determined by the largest dimension of the solid portion of the CT scan or the invasive portion. Tumor size subdivided into 1 centimeter increments up to 5 centimeters. And then he said if it's more than 5, less than 7, equal to 7, classified as 3, more than 7, classified as 4. And then he said the difference was tumors involving the main bronchus or causing lung athalexis or obstructive pneumonitis now are called as T2. Previously, some of them were actually called as T3. Tumors involving the diaphragm are called as T4. Previously, it was called as T3. And then tumors that were involving single distant extrathoracic metastasis called an M1B, multiple extrathoracic metastasis M1C. Previously, both these were called as an M1B. So this is just the quick difference between the two. Also, another interesting paper, the new 8th TNM staging system of lung cancer and its potential imaging interpretation pitfalls and limitations with CT image demonstrations. So he first talks about the importance of the new classification of the TNM system, and he says that the multivariate Cox regression analysis adjusted age-sex histological type and geographical region was used to evaluate the T descriptors. And the reason why they put them at 1 centimeter intervals is that they found a 5-year prognosis for every centimeter increment in tumor size. So in other words, that he realized that every 1 centimeter change in a tumor size actually has an impact on the 5-year prognosis. So the cutoff point of 5 centimeter further separates T3 from T2 because, T2B stops at 5, but then if it's more than 5, it's T3. And you realize that there's quite a significant decrease in 5-year survival when it's more than 5 centimeter, which drops down to 52 to 57% compared to 60 to 65% if it's less than 5. And then additionally, there's a difference between T3 and T4. T4 is more than 7 centimeters, and you'd realize that the 5-year survival drops down to 38 to 47% with T4 tumors that are more than 7 centimeters compared to the T3 tumors. And this is the reference down there if you would like to have a look at it. Then he talks about the importance of classifying the exothoracic metastasis into M1B and M1C. And he says that for exothoracic metastasis, there seems to be a significantly superior prognosis for those with a single metastasis in a single organ than those with multiple metastatic lesions in one organ or multiple metastases in multiple organs. So you should know the difference between both, and that single metastasis in single organ has a different prognosis than multiple metastatic lesions in one organ or multiple metastases in multiple organs, which is the difference between the M1B and the M1C. And again, you've got the reference down here. So what are the pitfalls and limitations in interpretation of the imaging system of lung cancer? So were there pitfalls? Yes, there was. Number one was the pleural invasion. It's quite complex because pleural invasion depends on invading depths. If you want to get more information about this, so the depth is a PL1 and a PL2 and a PL3. This is quite one of the important factors in the 8th edition of the TNM staging system. So for instance, PL1 is actually invasion of the elastic layer of the visceral pleura without reaching the visceral pleural surface. So just the elastic layer. But at PL2, that means it reached the surface of the visceral pleura. And at PL3, that means it reached the parietal pleura. So if it's just limited to the visceral pleura, if it's only on the elastic surface, it's called PL1. But if it goes full thickness visceral, it's called a PL2. And if it reaches the parietal pleura, it's called a PL3. While the PL1 and the PL2 are limited to involvement of the visceral pleura, they're classified as T2 tumors. But once it reaches the parietal pleura, we classify that as a T3 tumor. Remember, we said chest wall invasion is T3, but visceral pleural invasion is 2. So what is the problem? The problem is to identify whether a tumor is actually limited to the visceral pleura or had actually invaded the parietal. Because there's no absolute criteria to identify pleural invasion or further differentiate visceral or parietal pleural invasion at clinical staging, particularly from a CT image. And maybe the most important, the most accurate way is actually when you find signs of destructions of the bone. So let me try to simplify this. To differentiate between a T2 and a T3 in terms of pleural invasion is that T2 is limited to the visceral, but T3 is limited to the chest wall. It's very difficult on a CT scan to say whether this invasion of the pleura is actually limited to the visceral pleura or has it actually reached to the point that it actually touched the parietal pleura, invaded the parietal. The only finding is that when you see evidence of bone destruction, then you are sure that the parietal pleura has been breached. So it's just one of the pitfalls that is available on a TNM staging system because of the difficulty in differentiating between these two. Another thing is that the node metastasis, because more than half of the data analyzed from the 8th edition for the CN component, which is the clinical nodes, which is the radiological component, they were collected from Japan and using something called the Naruka Japanese map, while the majority of the rest were assessed by the Mountain-Dressler modification of the American Thoracic Society. So what is the problem? The problem is actually these two nodal maps are different because of the subcarinal space. The Japanese map divided or classified or defined the subcarinal stage as stage 10, while the other map considered them as station 7. So therefore, there is no unification of the lymph node map categorization. One said that the subcarinal to them were the station 10. The other said that the subcarinal were the station 7. Now we know the subcarinal is a mediastinal lymph node, but there are different mapping systems, and therefore the N1 and N2s were not very accurate in this. And for that reason, they think that unification of the lymph node map would become very, very important to get more accurate staging and better results. I hope that you had enjoyed this TNM staging system and had learned something from it. Thank you very much. Thank you.